Professor. I'm so honored that I have you here with me talking about congenital orthopedic disorders. And the first question that I want to ask you is, what are the most common congenital orthopedic disorders and how do they affect the complete child's development?
Thank you for having me. It's an honor to be here as a guest. One of the commonly complaints of the families coming to me asking whether their child is walking right, if their toes are turning in or they're flat, sort of things. But most of these problems that are raised by the families are naturally part of the normal development. And most of them just grow out of them and just become normal looking functioning feet eventually. But some might need further intervention in the later childhood. I have a special interest in children's orthopedics limb deformities that may present with some bowing, angular deformities or shortening of one extremity versus the other. So I see a little bit more of the problems that might occur maybe, but these are one of the few examples that came to my mind.
But you said limb deformities. Are limb deformities mostly diagnosed in utero or they're diagnosed after birth?
Well, you can talk in two ways. The ones that occur congenitally, that are by birth, could be diagnosed in utero. And the ones that occur after birth due to such as trauma or an illness that happened in the childhood can develop and present this problem in the later childhood. And those are called post-traumatic deformities. But mainly the problems that are seen congenitally, by birth, it can be diagnosed in utero. And yeah, I see quite often pregnant ladies coming into my office asking questions about their expected child having some sort of turning in of the foot problems or other limb length difference.
Or some deficiencies.
Or some deficiencies, yes. Sometimes the child is diagnosed with the short limb versus the other side. And that might be a sign of several diseases, to name a few: fibular hemimelia, tibial hemimelia, or congenital femoral deficiency.
Just to explain to interlocutors, hemimelia means that a part of the bone is missing or the whole bone. Am I right?
Could be both. Either the bone is absent or hypoplastic, meaning less in size or length. And it also comes with the problems of the tissues around the bone as well. So just not the bone, but bone and the muscles and the soft tissues around. So such children, if they are having an hemimelia type of a disease, are born, and then when the baby is born, it is obvious that one side is shorter than the other side or thinner than the other side, and this will increase in diameter and length. The difference will increase as the child grows. So then a real future plan has to be made with the family to give them an idea of how many centimeters in length that this child will have a difference when he or she reaches skeletal maturity.
Yes, but when it's problem with length, in medicine there is always time. We think about time and we say we need to do things in the right time. So right now there is at the birth there is a difference in length. Does it mean that you perform surgery sooner the better, or you wait to see development until some phases and then you think that this is the best time for surgery?
To be able to explain that question, I have to give you an example. So, for example, if you're talking about length only, obviously this has to be planned out, and a time frame needs to be given to the family at what age is best to start doing these surgeries. And it's not usually in the infancy. It's usually in the later childhood, at least at the age of 3 or 4, to be the first lengthening and then probably at 6 to 8 years or 10 years of age in certain cases for the next cases. But if you are talking about correcting the deformity, and so preparing it for lengthening, then you don't have to wait for so long. And we usually perform such corrective surgeries at the age of 1 year of age, or a little more than 1, maybe between 1 and 2, just to get the baby, the child, prepared for future lengthening surgeries. But having said that, this is only for a spectrum of disorders that have limb length discrepancies that occur by birth, congenital, so to speak. But also we have problems such as club foot, which is called club foot, meaning a foot that looks like the club of a golf stick, that turning in a little bit, and this is diagnosed in utero, and the family so have an understanding of what they expect, what they should expect in terms of the child's foot, and also for the treatment period that they have to undergo. So for example, in a child with club foot, what I tell the parents who are coming to my office before the delivery of the child, to just calm down and then relax and enjoy the rest of their pregnancy, and then just give us a call about a week or 10 days after the birth, so that we can do the first initial exam and make a plan for them. And in most of the cases with patients with club foot, we usually start a treatment right at the age of 10 days to 2 weeks after birth.
That early?
Yeah, and it's not the surgery though. It's just the manipulation and casting of the foot deformity to, in a way, molding it to correct it to the normal shape. And this takes some time and effort. And I use the world-renowned Ponseti technique for clubfoot, and I have been trained and visited him personally about, I would say, well, it's been a while. It's about 13, 14 years ago.
13, 14?
Yeah, he was doing his clinic at the age of 94, and he was still bright-minded gentleman. And so millions of patients are getting benefit from this technique worldwide. And I also use this technique, and following the technique that we do as a Ponseti followers, we do casting and manipulation and casting weekly, and then at some point where the foot is ready to undergo a surgery, so-called a minor surgery, that helps us to reach the normally corrected position of the foot. Once once that is reached, it's probably the baby is around 6 weeks to 2 months of age. And after that, the family becomes happy to see the child's corrected, normal-looking feet.
And normal development.
And normal development, yes.
Yes, which is a huge thing. Yes, I saw some of your pictures before and after surgery, and I was really amazed with the results. So the child continues normal life.
And they don't even remember what they had when they were born.
That's also a good point of view.
Sometimes I challenge these kids, and they come to my clinic.
Do they remember you?
Well, not that, but for example, at 3 or 4 years of age, or sometimes 2 years of age, and they come to my clinic with their parents, and then they look at me, and I ask the individual child, "Why are you here for?" And they said, "I don't know. My parents brought me in." And I said,
great.
"So why are you here?" "I think I have to show my feet for a new pair of shoes." They don't even know what's going on with their feet.
But that is really a satisfaction.
Yeah, I get a lot of satisfaction from that. Yeah,
absolutely. And one disorder that is really common, and young parents always are afraid of hips. Are hips okay? Are they formatting okay? So those developmental hip deformities are one kind of problem. Can we explain to people why does those problems occur?
Well, these hip problems occur with some reasons that we cannot explain fully, but we know that some individuals are at higher risk. So, for example, the firstborn girl, infant, has a higher risk for some reason than a boy infant in a woman who is having her first child. And if this runs in the family, the risk is a little bit higher. And if the mother has a little bit of less amniotic fluid, and then this risk is a bit higher, so that the baby is packed a little bit in the position in the utero in a packed position. So if the baby is not freely moving and stuck on one side, and that hip, it tends to develop less than compared to the other side. So what is accepted in today's modern medicine is to examine these babies' hips after they're born, and then beyond the examination, we usually recommend doing hip ultrasonography to make sure the hip is developed normally.
At what time and how regularly should you do the exams and ultrasonography?
I usually recommend to bring the baby to the office at around 4 weeks of age after birth for an initial exam. So it could be between 4 to 6 weeks for getting a hip ultrasonography at the first stage. And then if the baby has some developmentally deficient hip, then I would repeat the hip ultrasonography at the second and the third month. And if the development is still deficient, then I would start the treatment with the so-called pelvic harness type of bandage that keeps and molds the hip in the functional position, so that the hip doesn't require any surgery to get it reduced. So it is possible to do a proper bandaging and giving instructions to the family to get it right. But sometimes it's just not possible for the baby to keep it on. The families get bored and they get frustrated and they cannot, do what we tell them to do. So eventually we sometimes face with babies or children who have some problems in the hip. And this could be an issue to come to a pediatric orthopedic surgeon. And in that case, we can offer them either to do a casting. Casting is usually under anesthesia, or surgery. The surgery could be a little bit minimal surgery or a little bit bigger surgery, depends on the condition and the age of the patient. But usually when it's done properly, it's just a once in a lifetime operation. They usually don't need any further surgeries. If it is run properly at the proper age with the surgical precision, etc. And it is one of the most rewarding surgeries in orthopedics and pediatric orthopedics, because you're giving a human being a second chance for growing until their elderly ages, not requiring any other surgeries. And sometimes it's not that possible, but most of the cases this is the scenario, I would say.
So that's great. So in the hip deformities, it is important the time to diagnose the problem, and then also to treat it as soon as possible. Right. And then it is just one surgery. Usually
it's a one surgery, but if the child is living in a rural area, they don't have access to medical care, wasn't diagnosed before, but let's say was diagnosed after he or she started walking, and once they start walking, we often see that they limp. So sometimes the family bring their children to us asking, why is this child limping? So one of the most possible scenarios that they might have a hip dislocation that was undiagnosed. And in that case, the surgery will be very successful solution to do instead of waiting. Because if you do a surgery at that age, you will get the best result with minimum surgery if it's done properly.
Yes. So for hip, the time is very important to do it. So one thing you mentioned to me concerning the limb lengthening, you perform limb lengthening both on children and on adults. Am I right?
Yes.
Is it more complicated with adults?
Medically speaking, no. For the equipment wise, I have to tell that it is easier to do it in adults because the adults are not growing.
Yes.
And the newer technology allows us to lengthen the bones by inserting a metal nail or stick into the canal of the bone. And without having wires or pins going across the leg. So this is a surgery that can be performed, and after the surgery you don't see anything on your leg, and just by doing a remote lengthener device, which is called magnetic lengthener, you just send signals to the nail, which also has a magnet inside, and then just do the lengthening without any pain and without any dressings, changes, less difficulty in physical therapy. So this is possible in older adolescents and adults.
Yes.
But in growing children, it is not so possible because of the growing potential. Because when you usually tend to violate the growth plate in children, small children, if you do it. And also the other thing, the constraining factor is that the diameter of the bone in children is smaller. So it has to be at certain width so that the nail can fit in the canal of the bone to be able to use this device. But other than that, it is easier in children, obviously, to lengthen this and get a better healing bone because the children are able to produce a better bone. They have a better quality
regeneration
bone.
Potential.
Yeah, for
yes.
regeneration potential. But in adults, if they're not smoking and if they also, do a good job in producing bone, we don't very much face with problems in regeneration.
I'm always interested to help my patients and my interlocutors watching the TV show. And then I need to ask you, since you're in Istanbul, in Turkey, what about patients who are not from Turkey, who are from abroad? Does the procedure differs for them? How long is the recovery period? How often should they come for some examinations?
Yeah.
Are there any differences, or it's absolutely available also for them?
Yeah, I have quite a few patients coming from abroad as well, from Serbia. What we offer them is we sit down and talk with their accessibilities and the options that they have, and considering the medical factors that we consider as a must, then we tailor the choices for their needs. Most of the cases, the surgery usually requires a stay of maximum 3 to 5 days in the hospital. And in some cases, they might need to stay in the city of Istanbul for another 2 weeks just for a follow-up post-operative check. And in majority of my surgeries, I usually do the first, official checkup or visit after 6 weeks to 2 months. And in the meantime, they cannot go home and do whatever they want within our instructions. In that time period, I do not expect any unexpected events because we will have watched them for 2 weeks maximum so that we know what's going on. And after that 1.5 to 2 months period, we usually check their post-operative condition and then tell them to come back in 3 months or to 6 months, depending on the condition and the surgery we have, completed.
That's great to know. Thank you so much for your time, and thank you for this beautiful conversation. And I'm sure that next time when you come to Belgrade, you will come to the studio and to participate in the show.
I will enjoy that. Yeah.
Thank you so much.
Thank you.